So actually, I'll start off with one that I got from somebody who left a little bit early. This is a very tough question for us. We all have to deal with it. This is honestly, my least favorite part of my job. I consider my job to give you independence rather than take it away. Here's the question. Is there a rule of thumb when a PD patient should be advised not to drive an automobile? So, worst situation I have to deal with, easiest way for me to make enemies with a patient. Their general rule of thumb in my mind is if it's unsafe or if you're concerned. This could be caused by numerous reasons. Any of the complications that anybody discussed today, obviously hallucinations, you don't want to be out driving and see a cat and turn the car into something. I will let you know that the rule of Nevada State is that if you do bring this up at a doctor's appointment, that we are advised by law to inform the DMV about this. So please be sure that you're ready to talk about this before you bring this up. But if you really, in all honesty, if you do consider this to be a problem, let us know. It's not an easy situation to handle, but it is our job, and we will help. Safety is the first and most important thing.
I'll do one of my questions. This says, how does stress affect tremors in the hand and lips? So any sort of stress can affect any sort of movement disorder. So it can be physical stress, it can be emotional stress, it can be intense joy. And it doesn't have to be Parkinson's disease, it could be essential tremor, Huntington's. All of these patients shake more with stress. If you think about somebody who doesn't have a movement disorder, who's really angry, you might see them shaking and they don't even have a movement disorder. So you can imagine with the movement disorder, it'll worsen. And then as the stress comes down, the shaking should come back to their normal baseline.
So I have a question. How do you manage the complication of dyskinesia? So this is something that relates to the talk that I gave, and the specifics as to how to manage dyskinesia will be very individualized to how severe it is, how important it is to the person. So first of all, I always ask the question, is it bothersome to you? Because obviously for this person who asked it, it is, but it's not obvious. I see a lot of cases where a patient is not even aware of their dyskinesias. It's the family that's pointing it out. And sometimes I see general neurologists who look at the patient, not even asking questions, see the dyskinesias because they are very obvious and sometimes dramatic, and then just cut the levodopa or do whatever it takes. And the patient wasn't even aware of their dyskinesia. In fact, they like it because that's the state when they can get up and get a glass of water and can move around. So first of all, always ask the question, is the dyskinesia disabling? Is it something that is worth managing or changing anything? Now, if you determine that it is bad enough, that it requires some kind of measure, then the number one question is the patient over-medicated? Because sometimes I see patients managed elsewhere who come in horribly dyskinetic, and that's because the doctor who managed them before has a generally binary management style. When the patient calls for a problem, they increase the levodopa. If they are fine, they don't increase the levodopa. And if that's the case, the simple answer is just lower the levodopa, and that will help the dyskinesias. Another option is that distribute the levodopa differently. Maybe rather than 300 milligrams 3 times a day, use 200 milligrams 5 times a day, or other ways distributing it better. There are also medications that include carbidopa-levodopa, or that's the active ingredient, but a slower release, such as Rytary, which is a new medication, and that does not produce the peak as high of the levodopa, also not going high as fast. Both of those factors contribute to dyskinesias. There are other options. I mentioned amantadine in my talk, which is an anti-dyskinesia medication. If that hasn't been tried, that could be one management option. And ultimately, there are advanced treatment options for too much dyskinesia, including DBS surgery and Duopa, which is a continuous infusion of levodopa.
If my
colleagues will permit, I'll answer a couple of these cards at once. Which hallucination would be most prevalent for patients diagnosed with Parkinson's disease? So the hallucinations that are most characteristic are visual hallucinations, usually well-formed. I am not sure, though, whether those are actually the most common or whether this presence hallucination, this sense that somebody is there, is actually more common but not complained about as much, not as dramatic, and usually not treated as much. Then there was another question. I know my hallucinations are not real and my family members think I'm crazy. How should I bring this up to my doctor? You should tell your doctor that your family members are crazy. But I would say one of the things to do, or the most straightforward way to approach it if you're talking about a neurologist, is to say, I know hallucinations can be a complication of Parkinson's disease. I am having hallucinations. What can you do to help me?
All right, I got a couple questions here. Is sleep apnea common among Parkinson's disease patients? I actually don't know what the percentages are for sleep apnea. I will tell you that sleep issues in general are hugely common. There's volumes written on sleep. Certainly having Parkinson's would not prevent you from getting sleep apnea. And sleep apnea is certainly common. I'll be honest, it's not something I typically think of first when a Parkinson patient complains of sleep issues. I think of some of the other things I mentioned, just the fatigue, sleepiness from medicines. Most Parkinson patients have trouble staying awake, not trouble going to sleep. And sleep apnea is sort of the other way around. The other question I wanted to answer was, it says, does Parkinson's affect the heart? I have discomfort, not pain in my heart. No results from cardiology tests. So, Parkinson's can affect sort of heart rate. That probably is some of how it affects blood pressure. Generally speaking, though, we don't think of Parkinson, of like chest pain coming from the heart being a Parkinson thing. If a patient has discomfort there and cardiology tests are all normal, I actually might think, maybe it's a breathing issue, maybe it's a rib issue, and it just feels like it's coming from the heart. But I don't typically think of the heart as causing problems, although if somebody complained of that, I would certainly have them see a cardiologist first to make sure it wasn't something else.
Let's see here. The next one is, if surgery is needed, what to do in I'm not sure what this is, but in relation, I think, to anesthesia. Also, there's a question of stem cell. So anesthesia can definitely worsen the symptoms of Parkinson's, mainly the cognitive. That goes with anything. It's a pretty common sense kind of a component. So if you're going to be given a sedative or an anesthetic, something that's going to basically push you to sleep, it's going to take longer to come out of that as we get older. So with Parkinson's, that can definitely worsen the symptoms. So it's something really you should not have to worry about yourself. The anesthesiologist, that's their job, but they can also talk with us, and we can coordinate the care. So you shouldn't have to worry about that if you are going to undergo a procedure. It is something that we consider, and all surgeons consider also in regards to safety. Not sure about stem cell therapy. I can touch on it. I can say that nothing has been proven in regards to stem cell therapy for Parkinson's disease. I defer to Dr. Mari in this regard, in regards to stem cell therapy and kind of advanced disease-modifying agents. I think Dr. Mari is more of an expert in that than I am.
Well, if we are there, I do have a question, actually, in terms of disease modification, which is, are there any therapies in the near future that will slow the progress of disease? So, as you know, there are none currently approved or proven that are currently in use, and that is the holy grail of Parkinson therapeutics, to find something. But we are finally quite close. I kind of alluded into this in my last time when I discussed some of the evidence. So the good news is that there is hope. There was one study for the first time ever that this summer was published in the Lancet Neurology, coming out of UK, where they found at least some compound, it's called exenatide, it's a peptide, that was effective in a 1-year single site but blinded and controlled study, slowing the disease progression by 1 point of the UPDRS, which is not tremendous, but you don't progress a whole lot within 1 year. So it's nevertheless a very, very reassuring clinical study, because prior to that, there have been many miraculous disease-stopping, preventing, and slowing agents in animal experiments that never translated into clinical trials. They all failed, one after the other. So now I think our animal models are better, so we can screen some of these candidate drugs much, much better, and we are seeing the results of that already. There was one a compound that actually translated into a positive human trial, and I predict that there will be several others that are coming out. I'm involved, or we are involved with some of them, and more are coming. So I predict that in the next 5 years, there will be a phase 3 clinical trial that will show benefit of a disease-modifying agent.
For a PD patient with delusions, paranoid, and hallucinations, is it possible to eliminate them or just manage them? Oh, to eliminate the hallucinations, not the patient. So yes, it is possible, although it is difficult to eliminate hallucinations and delusions. We tend to get more control over the degree of preoccupation and the extent to which they affect the individual's life. So I would estimate, and I haven't formally studied treatments in my hands, but I would estimate that somewhere around a third of individuals with hallucinations and or delusions, I'm able to eliminate them completely. Most patients, I would say probably 75%, we're able to reduce them to some degree and have an appreciable impact on quality of life. And a follow-up question that was also on another card, should I see a psychiatrist or neurologist for psychosis? And another person asked for psychosis or depression. And it really depends on the comfort level of the, I would say, I guess, of the neurologist to start with. You know, if you can get your care integrated so that one person knows everything you're on and they are adjusting all of the medications in concert, that's probably ideal. That's not to say that you can't get extremely good results from separate people, but you're certainly better off if your neurologist says they don't feel comfortable with managing those symptoms to have them managed by a psychiatrist. I also give the caveat that some psychiatrists don't feel comfortable or don't have a lot of experience with managing psychiatric complications of Parkinson's disease. So you want to ask that specific question before you go and see them. I have Parkinson's disease. I think these are complications. Is that something that you can handle? We're all trained to do it, but there's a variable degree of comfort with doing it after you've been in practice, maybe doing other things for a while.
So there's a couple of questions here that I'll answer, and then on this one card, there's one that I'm going to pass on to Dylan. So the first question is can change in appetite be related to loss of smell? So Parkinson's patients definitely have reduced smell, oftentimes before their diagnosis, and it can definitely reduce appetite because it can reduce taste. Plus the apathy can reduce appetite. Plus shaking, you may lose weight just from shaking, from burning calories. So there definitely can be weight loss and loss of appetite from sense of smell. Sometimes you have to do, multiple small meals or just timed eating, that sort of thing. And the next question, it's on 2 cards, and probably wouldn't be a Parkinson talk without this question.
Make that 4 cards.
4 cards. I will read them all. Number 1, marijuana usage while taking Sinemet. Number 2, thoughts on use of THC CBD for treatment of Parkinson's. Using marijuana to benefit Parkinson's. Is cannabis oil for PD? Is there any benefit for marijuana on the symptoms of PD? I get asked that question every day. I'm surprised it was only on 5 cards. So I will tell you what I think. I don't know if these guys will disagree with me. So right now, as the literature stands, we have very bad studies that suggest marijuana, THC, CBD can be helpful, and we have very bad studies that suggest it can be harmful. There are reasons to think it might be helpful. There are THC receptors, there are cannabinoid receptors close to the dopamine receptors. On the other hand, what are some things that THC might do? It might slow your thinking. It might, slow your movement. And what does Parkinson's do? So I think right now, we don't have enough evidence to recommend it. And this isn't like some disease where we don't have treatment. We have a lot of treatments. So I would recommend using the treatments. In Nevada, you can just buy it. I don't recommend it, but you don't even need a doctor's prescription. I would recommend using the money you're going to spend on marijuana, cannabinoid oil, THC, and go on a cruise. And if you don't like cruises, send me on a cruise, okay? So I don't know if you guys disagree, but that's sort of my overview of the literature for marijuana.
I get that question pretty much every day, especially about the CBD. And so essentially there's a CBD and a THC. I call the THC the Woodstock part of marijuana. Yeah. And the CBD is more of the medicinal part. And there have been a lot of studies. Actually, one of the colleagues of Dr. Mari here, I worked with at UCSD, and he did a study with CBD on tremor. And they have not borne out to actually prove that they can improve tremor significantly, but they have shown some trend towards doing so.
I confirm that. I mean, a lot of times I get asked in a clinic, and my general position is that I wouldn't ever stop something that helps the patient. We cannot currently prescribe or recommend it. It's not on label. It can be used off label, and if it's something that helps you, I condone that. I would like to add one small comment to the question about the olfaction and appetite. We use our olfaction quite a bit to our appetite. As much as we sense most of the food's taste with our sensory, the gustatory buds in our tongues and mouth. 30% or 40% of the taste actually comes from intact olfaction, and so that actually is a contributor to why people don't enjoy food as much and lose weight as a result. So I had two questions relating to DBS. One is, can you share any info about new DBS therapies besides Medtronic? And the other one is, how long will DBS last? I don't think I can share anything besides Medtronic, can I? But anyway, so basically, there are some new therapies. Medtronic itself is coming out with a bunch of innovations. They are currently getting FDA approval for the segmented lead or directed lead, which are leads that allow the programming physician to use a other than spherical shaped stimulation field. So that's an important innovation. The other thing is that the programming efficiency is being improved in many ways. St. Jude is a company that has come out recently and represents some of these novelties, but Medtronic is also working on that, and there is another company, Boston Scientific, that comes out with their own product sometimes in the future. So you can also get more info about DBS from the desk in the back. How long will it last? Well, that's a very good question. I mean, we do have some long-term studies now, observational studies, which go back for more than 10 years. One thing that you have to always remember when asking this question is that DBS is not going to stop Parkinson's disease or reverse it or slow its progression. So as much as DBS is effective, and it will help the right candidate, the patient who is appropriately selected for this therapy, it will always work. So the answer is, it will last as long as it's going, as long as you have it. You will always be better for improving the symptoms for why DBS was implanted in the first place, but you will be worse off overall years and years later because of the progression of the underlying disease. It's not that DBS is going to fail, it's just going to fail to appropriately treat all the new symptoms and the severity of the symptoms that you will have 10 years from now with a more severe disease. So keep that in mind.
Does long-term Parkinson's disease qualify for long-term health insurance payment? That does depend on the specific plan. Most of the plans that I've seen are defined based on the person's function, so not defined by disease per se. It's usually when the person has lost ability to perform some activities of daily living, and then the diagnosis that has caused that is secondary, and what they really want to know is this is going to permanently affect those abilities. So you would have to check your insurance policy, but generally, at the point when Parkinson's starts to interfere with activities of daily living, it should come under long-term insurance. Somebody wrote on the back of this card, did she bring her purse? And I don't have the data to answer that question. My husband has no interest in anything other than lying in bed watching TV. When he exercises, I see immediate improvement. I have trouble getting him to exercise. Any ideas? First, I'd like to thank my wife for coming. Secondly, sometimes being in a formal exercise program can be really helpful. So if you can get them involved in physical therapy or in a gym membership for which they're paying and they may not want to waste the money, that is sometimes helpful. Exercising together can be helpful. There's unfortunately no tried and true strategy that I've developed, but another question to ask is whether that reduction in motivation to exercise, which clearly does him some good, is that lack of motivation related to apathy or depression, which occur in Parkinson's disease, and are those things that might need to be treated? Those are some ideas off the top of my head.
One other thing to add to that is when people say what exercise to do, how do you get them in? Do what exercise you'll stick with, right? If you hate running, don't run. You know, if you hate biking, don't bike. Do something that you're willing to stick to.
And this is a theme. This is actually another question I got here. What forms of exercise are thought to be best for maintaining balance, motor function, and cognitive function? I agree with Dr. Farbman completely. Specifically, what has been recommended for Parkinson's disease for balance is Tai Chi, yoga, boxing. There's various boxing programs here in Las Vegas. And if you think about it, all the problems with Parkinson's, there's slowness of movement, the postural instability. Those are all things that are of value in boxing. Don't come back and hit me, please, and just to take the boxing courses lightly. Thank you.
There is a question asking, will plant protein or protein in general have a negative effect on the medication of carbidopa-levodopa? So there is a controversial and oftentimes discussed issue as to how you should time your meals with regards to the timing of your carbidopa-levodopa. Will the meals and specifically the protein content have an effect? So the answer is it depends. I usually tell patients in the earlier stages of disease that don't worry about it because at that time, in the earlier stages, you have a very significant dopamine buffer. So even though meals and especially protein content will slow the absorption of levodopa, but it will get in there eventually, and it will be stored with the still remaining pool of dopamine neurons and released later on over many hours. And so therefore, the impact of protein in the meal and the early stages of Parkinson's disease is not significant. In fact, sometimes I recommend taking the carbidopa-levodopa with meals so that we can reduce the nauseating effect, and that's perfectly all right in the beginning. In advanced disease, it changes, and increasingly timing the meals, and especially protein content, becomes a very important factor because it can make the absorption delayed, slowed, and unpredictable. When somebody doesn't have as much dopamine buffer anymore, and the availability of dopamine in the brain begins to resemble the levodopa level in their blood increasingly, then how the levodopa gets into their bloodstream will determine how they are on and how they turn on and how much they will be off. So in that case, I recommend levodopa to be taken on an empty stomach where that sort of variability and impact of the protein is less. And maybe at night you can take a big shrimp salad or tuna salad when you're going to bed and you're going to be sleeping. So that's when I usually recommend if somebody likes to have protein, because protein is important in maintaining muscle mass, which is on attack in Parkinson's disease. We are losing muscle mass in Parkinson's disease. So you need protein, but try to time it at near the end of the day or the last meal in more advanced disease.
Got another one here. This is a little bit more specific, but I think we can generalize this. It's I'm being treated for Parkinson's, depression, and dementia. Could any of my medications or treatments be negatively impacting any of my conditions or causing any negative side effects, such as confusion, anxiety, loss of appetite, loss of memory, weight loss or energy loss, inability to perform everyday activities? And if you remember Dr. Wendt's slide on kind of the depression symptoms, I think this basically meets all the criteria for many of those symptoms. Technically, for that slide, there was 9 symptoms. You need 5 of those to meet criteria for major depressive disorder. Ultimately, though, to generalize this, it's always hard to tell what's doing what. And I think that if you look at what temporally correlates with your symptoms, if you start a new medication and all of a sudden this happens, I think you can't conclude, but you can kind of infer that that might be the cause. And always bring it to our attention. I tell everybody that I see, don't be shy. Please let us know. I think we all feel that way.
Are there service dogs trained for a PD individual? So my understanding of the ADA definition of service dog is, or service animal, is an animal that is trained to perform a specific task for an individual with a liability or disability. So I should think that there are some things that a service animal could do for someone with PD, but I don't think there would be such a thing as a PD service dog. It might be a service dog, you know, to help with gait or something like that. So I would think that there are service dogs who can be trained to perform particular tasks that would be important to someone with PD.
There's an interesting question about what to do if somebody is completely a non-PO, that can only take nutrition and IV. Usually in the hospital, it happened to a friend of this person asking the question. So there are no good IV alternatives to Parkinson medications. Unfortunately, that's the case. I was at Johns Hopkins until recently, where we worked out in the local pharmacy an IV formulation. So in some institutions, it is possible. Dr. Jay Nutt, who is in Oregon, was the pioneer in developing the IV levodopa, but frankly, it is still not available generally on most hospitals. It's not available. So what can you do? Well, not too many things. So as I mentioned in my talk, we try to get rid of everything but levodopa in cases of acute illness. Now, if somebody is otherwise able to tolerate dopamine agonists, or maybe they were on dopamine agonists and they are not as delirious, but they are on a need on IV only treatment because of a gastrointestinal problem or a surgery or whatever, you can try the patch, the Nupro patch, which is a dopamine agonist that is available in parenteral form. In Europe, there are apoquine or apomorphine pumps as well. It's a subcutaneous pump which can be used in patients who cannot take PO pills. And finally, there is a orally disintegrating form of carbidopa-levodopa called Parcopa. Unfortunately, I don't have a very good experience with it. While I was at Hopkins, I did a lot of inpatient work, and we had patients in that very situation that this person is asking about. And we tried, before we had IV levodopa, we tried Parcopa. Most of the time, the patient just keeps it in the mouth, and eventually it falls out, and it doesn't really get into the system. So there are no good solutions for that. All what I said was like workarounds that sometimes help a little bit. And finally, I have two very quick questions. The first one is, why is there a shortage of carbidopa-levodopa ER medicine? So I don't know. I don't know if others know in this. I know about the shortage. I think it's a matter of profitability and other.
Well, I think some of it may be from the floods in Puerto Rico.
No, I know patients are getting it from Canada and all over the place. I think there is just not enough incentive in the generic makers industry because of financial considerations. I don't think there is a federal regulation that tells generic makers what to make. Their decisions are based on many factors, and one of them is profitability. So I don't know the answer. The good news is that we do have these workarounds, and while it is not available in the United States, domperidone is also not available, and so we can get these medicines from Canada. And the last question is there a recording of the talks? And yes, there's a camera, camcorder in the back, and so we are recording all of this. And I don't know how and when it's going to be available, because I also had a lot of patients who asked about availability of this. Maybe Leanne can comment on that, but a lot of people couldn't make it, so we hope to make them available to you later.
As soon as we bleep out the curses, we will put it online.
There is one more question, I'm sorry. This is a straightforward one. Where can we receive assistance for caregiver support, trainings, et cetera? We have several support groups here. There's Friends of Parkinson's, led by Jamila Ali Rahman. Also, there's National Parkinson's Foundation, which changes its name frequently, that you can find online as well. And we're always here if you need any support.
Thank you.
All right, thank you so much.